practitioner student with Maryville University. Today I will be performing a head-to-toe physical assessment on my patient. This is for advanced health assessment. As the patient walked in, I will get a general inspection of his appearance. He appears well-groomed, he was dressed appropriately for the weather, and he had a steady gait. Then I will introduce myself to the patient. Hi, my name is Abbey Meyer. I'm a nurse practitioner student who will be performing your head-to-toe assessment today. Next, I will offer him the time to empty his bladder in case he needs it. Do you need to go to the bathroom?
No, ma'am.
No. And then I will allow him to change into a gown, which he has already done. Next, I will get a full set of vital signs, including a blood pressure, heart rate, respiratory rate, oxygen saturation, temperature, and a height and a weight. All of those were within normal limits. So first, I will start with the head. I will do a general inspection of the patient's face and head. His head appears normocephalic, and it is upright on his neck. The patient has a few papules on the forehead today. He is without any scarring or lesion on the face. I will assess the symmetry of his eyes and his ears. The inner canthus is in line with the top of his auricle of his ear, meaning both his ears and eyes are symmetrical. Next, I'm going to inspect his scalp. Hair distribution is even on the entire scalp. He has thick, coarse, dark hair. I'm going to palpate the scalp. Any tenderness?
No.
No. Scalp is freely movable along the skull lines. Next, I'm going to palpate his facial bones. Let me know if you have any tenderness.
No.
No. He has no tenderness when palpating the facial bones. There was no deformities or swelling when palpating the facial bones. Next, I'm going to palpate his lacrimal apparatus. He has no swelling or excessive tearing in the lacrimal apparatus. Now I'm going to palpate his frontal sinus. Any tenderness?
No.
And his maxillary sinus. Tenderness?
No.
No tenderness at either of his sinuses. Next, I'm going to have the patient smile. Puff out your cheeks. Squeeze your eyes real tightly shut. Right, and then clench your teeth for me. All right. Patient's facial movements were symmetrical while he did this. His cranial nerve number 7, the facial nerve, is intact. I'm going to palpate his TMJ right now. Please move your jaw from side to side. Great. Patient has great range of motion of his temporomandibular joint. Next, I'm going to test his light sensation on his face. I'm going to have patient close his eyes. Tell me when you feel the cotton ball touch your face.
Now. 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 Now.
Great. Patient has great light sensation on his face. His cranial nerve number 5, the trigeminal nerve, is intact. Now I'm going to move on to the eyes. I'm going to inspect the external eye first. Close your eyes for me. His eyebrow extends the entire length above the eye all the way to the outer canthus. His eyelashes extend the entire length of the eyelid. Eyebrows are thick and coarse. He has no lesions or swelling on the eyes, no paraorbital edema. Open your eyes. He has no ptosis when opening his eyes, and they open evenly. Next, I'm going to inspect his conjunctiva. Conjunctiva is pink and moist, no evidence of any jaundice or paleness. Now I'll look at the sclera. Sclera is white, no evidence of any redness or jaundice. Now I'm going to assess patient's red reflex using my ophthalmoscope. Patient has great bilateral red reflexes. Next, I'm going to assess patient's vision using the Rosenbaum pocket chart. If you hold it out here, please read to me the lowest line possible that you can read.
4, 2, 8, 7, 3, 9.
Awesome. Patient has 20/20 vision with corrective lenses in place. Patient's cranial nerve number 2, the optic nerve, is intact. Now I'm going to assess patient's pupillary response to both direct and consensual light. Pupils respond and constrict appropriately with direct light. Pupils also constrict to consensual light as well. Next, I'm going to do the cover-uncover test. This will test for any strabismus. I'm going to cover patient's one eye. I'm going to have him look at a distant object in the room with the other eye. I'm going to uncover. No strabismus was noted. Do the same with the other eye. Again, no strabismus was noted. Finally, we're going to do extraocular eye movements. I'm going to have the patient follow my finger to the 6 cardinal fields of gaze. All right, great. Patient was able to do that correctly. Patient's cranial nerves, number 3, the ocular motor nerve, number 4, the trochlear nerve, and number 6, the abducens nerve, are all intact. Next, I'm going to move on to patient's ears. We had already assessed the symmetry of the ears earlier in the exam. I'm going to look at the outside of the ears. Auricle and pinnas have no lesions or swelling on them. I'm going to palpate. There's no tenderness on either auricle or pinna. Next, I'm going to have the patient stand up. I have him stand up here. I'll stand over here, out of the line of sight, and we're going to do the whisper test. I'm going to whisper 2 to 3 letters or numbers, and he was going to have to repeat after me.
4, 5P.
That is correct. Now we're going to switch sides.
8, 9S.
Correct. Okay, sit down. Patient was able to do the whisper test correctly. Next, I'm going to do the Weber test. I'm going to put the vibrating tuning fork in the midline of patient's head. Please tell me if you can hear it equally on both sides or more on one side versus the other.
Equally.
Great. Now we're going to do the Rin test. The Rin test assesses air versus bone conduction. Air conduction should be twice as long as bone conduction. First, I'm going to put the vibrating tuning fork on patient's mastoid process. Tell me when you stop hearing it.
Now.
And then move it to the front of his ear. Tell me when you stop hearing it.
Now.
Great. Patient's air conduction was twice as long as bone conduction. Now we're going to do it on the other side. Tell me when you stop hearing it.
Now. Now.
Excellent. Patient's cranial nerve number 8, the vestibular cochlear nerve, or the auditory nerve, is intact. Finally, on the ear, I'm going to use my otoscope to look inside patient's ear canal. Patient's ear canal is free of any redness or excessive wax. His tympanic membrane was easily visualized. It was pearly gray and translucent. There were no signs of any perforation, bulging, or redness. Move to the other side. Patient's right ear was free of any redness or excessive wax in the ear canal. His tympanic membrane was visualized easily. It was pearly gray and translucent. There was no evidence of any redness, bulging, or perforation. Now we're going to move on to the nose. Patient's nose appears in the midline of the face. His septum appears to also be midline. There's no evidence of any tenderness.
No.
No evidence of any tenderness, deformity, or lesions on the nose. Now I'm going to occlude one nair and have patient breathe in and out. Now on the other side, breathe in, breathe out. Bilateral nairs are patent. Now I'm going to assess inside a patient's nose. Right. Patient's nose is free of any redness or rhinorrhea. His turbinates are not enlarged. I'm going to ask you if you smell anything at this time.
Freshly cut grass.
Patient's cranial nerve number 1, the olfactory nerve, is intact. Now we're going to move on to the mouth. I'm going to assess the outside of patient's mouth. Lips are pink and moist. There's no evidence of ulcerations or lesions on the outside of the lips. I'm going to ask you to open your mouth. The buccal mucosa is pink and moist. No evidence of any ulcerations or lesions or discoloration. Now I'm going to look at patient's tonsils, uvula, anterior, posterior pillars, and posterior wall of the pharynx. Stick out your tongue. All right, patient's tonsils are 1+. They're not enlarged, they're not red, and there's no exudate present. They are pink and moist. The anterior posterior pillars are also pink and moist with no evidence of swelling or redness. Uvula is midline and it is pink and moist, no evidence of redness or swelling. And the posterior wall of the pharynx is also pink and moist with no evidence of redness or swelling. Now I'm going to look at the patient's tongue. Please stick out your tongue. I'm going to look at the tongue laterally and underneath. Great. Patient has no lesions, discolorations, or ulcerations on any part of the tongue. I'm going to have you stick out your tongue. Move it from side to side. Excellent. Patient's cranial nerve number 9, the glossopharyngeal nerve, and number 10, the vagus nerve, are intact. Now I'm going to palpate the hard palate and the soft palate of his mouth. No evidence of any swelling or lesions in the mouth. Now we're going to move on to the neck. Or actually, before I move on to the neck, I'm going to test patient's gag reflex. Patient has a great gag reflex. I'm also going to have you say ah.
Ah.
Patient's uvula did rise midline while saying ah. Next, now we're going to move on to the neck. First, we'll inspect the outside of patient's neck. Neck does appear midline. The trachea appears in the center and is not deviated. There's no evidence of any scarring or swelling on the neck. Please move your head against my hand. Good. Other side. Excellent. Shrug your shoulders. Great. Cranial nerve number 11, the spinal accessory nerve, is intact. Now I'm going to palpate patient's carotid glands separately, of course, or carotid arteries separately, of course. Great. Great. Carotid arteries are 2+. They're strong and equal. I'm going to palpate patient's trachea. Trachea is midline, no evidence of deviation. Next, I'll palpate the thyroid gland. I'm going to have you move your head forward and over. Please swallow. All right. Thyroid gland is smooth. There's no evidence of enlargement, goiter, or nodules. I'm going to palpate his lymph nodes. I'm going to do occipital lymph nodes, postauricular, preauricular, tonsillar, submandibular, submental, superficial cervical nodes, posterior cervical nodes, deep cervical nodes, and supraclavicular nodes. There was no nodal enlargement or tenderness on in any of these lymph node sites. Next, I'm going to auscultate patient's carotid and thyroid for any bruise. I'm going to auscultate with the bell of my stethoscope. No bruise were heard at the carotid or the thyroid. Now I'm going to have patient take off his gown to the waist anyways. I'm going to assess his upper extremities. Hair distribution is equal on the upper extremities. There's no evidence of swelling or scarring or lesions at this point. I'm going to palpate the upper extremities. Any tenderness?
No, ma'am.
No tenderness were felt on palpation. He had equal muscle tone on both upper extremities. Patient's hands are coarse. Patient's nails are pink and translucent. There's no evidence of any splitting, pitting, or pitting. Nail edges are jagged and short, probably from biting. Next, I'm going to palpate bilateral brachial pulses. Brachial pulses are strong, 2+ and regular. And now radial pulses. Radial pulses are also strong, 2+ and regular. Now I'm going to have the patient, you can get up and face the back this way. So you can sit back down. I'm going to assess the posterior back. Patient's posterior back does have scattered brown nevi, less than 1 millimeter in size. I'm going to palpate his spine. Any tenderness over the spine?
Nope.
Spine is midline with no tenderness. There's no evidence of any kyphosis or scoliosis. I'm going to palpate his costovertebral angle. Any tenderness?
Nope.
No tenderness at costovertebral angle. Now we're going to percuss the costovertebral angle. I hear good resonance at the costovertebral angle. Next, I'm going to see his thoracic expansion. I'm going to place my thumbs at the 10th rib. Deep breath for me. Patient has great thoracic expansion. Now I'm going to palpate for the tactile fremitus. Please say 99.
99.
Excellent. Patient, awesome tactile fremitus. Now I'm going to percuss the posterior and the lateral chest. I'm getting great resonance on percussion. Sharma. Okay. Excellent. Next, I'm going to percuss for diaphragmatic excursion. I'm going to have the patient take a deep breath in and hold it. I'm going to percuss down mid-clavicular line until it changes from resonance to dullness. And make a mark. Do the same on the other side. Alright. And next, I will have the patient take a deep breath in and blow it out and hold. And I'm going to percuss up from this line until I hear dullness. Or until I hear resonance again. Okay? Now I'm going to do the same on the other side. Great. Next I'm going to measure the length in centimeters between these 2 points. Diaphragmatic excursion should be between 3 and 5 centimeters in length. Patient's diaphragmatic excursion is exactly 4 centimeters on both sides. Next, I'm going to auscultate patient's breath sounds, both posteriorly, laterally, and anteriorly. Deep breath. Have you turn around. Okay. regular breath sounds in all lung fields. Patient did not have any adventitious breath sounds such as wheezes, rhonchi, crackles, or pleural friction rub. Now I'm going to inspect patient's anterior chest. Patient's chest rises and falls symmetrically. His respiratory rate is about 14 breaths per minute. No evidence of any scarring on the chest. No evidence of any masses or lesions at this point. I'm actually going to have you off the stool. Lay down here. Alright. Next I'm going to palpate patient's chest. I'm going to start at the left nipple area. Let me know if you have any tenderness. Then go at the left sternal border and to the top of the sternum. There was no tenderness on palpation, and I did not feel any heaves, thrills, or pulsation on palpation. I'm going to locate patient's apical impulse. It's at the 5th intercostal space, at the midclavicular line. Patient's apical impulse is 64 beats per minute, and it is strong. Now I'm going to percuss patient's anterior chest. Patient has great resonance on percussion on the anterior chest. Now I'm going to listen to patient's heart sounds at all 5 areas. I'm going to start with the aortic area, which is the 2nd intercostal space at the right sternal border. I'm going to move to the pulmonic area, which is 2nd intercostal space at the left sternal border. Then I'll go to Erb's point, which is 3rd intercostal space, left sternal border. And then the tricuspid area, which is 4th intercostal space at the left sternal border. And finally, to the mitral area, which is 5th intercostal space, midclavicular line. S1 and S2 were heard in all 5 of those areas. There was no evidence of any murmurs, S3, S4, or splitting. Now we're going to move on to the abdominal assessment. I'm going to inspect the abdomen first. I do not see any evidence of any protrusions or scarring on the abdomen. Patient's umbilicus is midline. Abdomen does appear flat. I'm going to auscultate for all 4 quadrants for bowel sounds. Patient has active bowel sounds in all 4 quadrants. Now I'm going to listen with the bell of the stethoscope to patient's aorta, renal arteries, iliac arteries, and femoral arteries for any bruits. Start with the aorta, renal arteries, iliac arteries, and femoral arteries. No bruits were heard at any of these points. Next, I'm going to percuss the abdomen. I'm hearing dullness over solid organs, like the liver and spleen, and I hear tympany over air-filled organs, such as the stomach and the intestines. Next, I'm going to percuss to see the size of the liver. I'm going to percuss down on the midclavicular line until it goes from resonance to dullness. Alright, and now I will percuss up on that midclavicular line until I hear tympany go to dullness. Alright, and then I will measure in centimeters the size of the liver. It should be between 6 and 12 centimeters. Patient's liver size is 6 centimeters. Next, I'm going to percuss for the dullness of the spleen. Right there. Excellent. Now I will do light palpation of patient's abdomen. Patient's abdominal muscles are firm. Abdomen is soft. Now we'll do deep palpation. Please tell me if there's any tenderness. No tenderness on deep palpation. Now I'm going to try to palpate the right liver border. Now patient, take a deep breath in. Breathe out. Liver border was palpated. There's no liver enlargement or any nodules felt on the liver. Next, I'm going to palpate the spleen. Deep breath in. Out. There was no splenic enlargement. Now I'm going to try to capture a kidney. Deep breath in. Out. Okay. Breath in. Out. I was unable to capture a kidney. Finally, I'm going to palpate for any aortic pulsation. Patient has no aortic pulsation. Now I'm going to have patient sit up again. I'll have the patient sit back on the stool. Put the gown back on. Now we're going to look at patient's lower extremities. Patient has equal hair distribution on bilateral lower extremities. He has no signs of any scarring, lesions, swelling, or redness. I'm going to palpate the lower extremities. Patient has equal muscle tone on bilateral lower extremities. I'm going to palpate the popliteal pulse. Patient's popliteal pulses are strong, 2+ and equal bilaterally. Next, I'm going to palpate his post-tibial pulses. Post-tibial pulses are 2+, strong and equal bilaterally. Next, I will palpate his pedal pulses. Pedal pulses are strong and equal bilaterally at 2+. I'm going to push against his feet. Any pain in the calves?
Nope.
Patient has no pain in the calves, so that is a negative Hohmann sign. Now we're going to move on to the neuro assessment. In the previous assessment, I have already assessed all 12 of the cranial nerves, and all 12 cranial nerves were intact. I have patient squeeze my hands. Right? Pull up. Push down. Excellent. Patient has great strength bilaterally. I am going to test sharp versus dull sensation. I'm going to use a safety pin. Have patient close his eyes. Please tell me if you feel the dull or the sharp side of the safety pin.
Dull. Dull. Sharp. Dull. Sharp. Sharp. Sharp.
Great. Patient accurately determined sharp versus dull sensation on his body. Now, finally, we're going to move to the musculoskeletal section. We're going to look at the deep tendon reflexes first. Do the patient's brachial reflexes. Great. Next, we will do patient's knee. Good. Other knee. Great. And finally, the Achilles. Great. Patient had very well deep tendon reflexes in all areas. Finally, I'm going to do range of motion exercises. Have the patient stand up. First, we're going to do cervical range of motion. You're going to bend your neck forward and back, and ear to shoulder again, and then turn chin to shoulder. Other side. Excellent. Then we're going to do lumbar range of motion. You're going to bend forward all the way back. You're going to twist side to side, and then you're going to bend side to side. Great. Patient has full lumbar range of motion. Finally, we're going to do the knees. You're going to bend the knee all the way as far as you can, and then extend. Other knee, and extend. Patient has full range of motion of bilateral knees. This concludes my head-to-toe assessment. Thank you for watching and hope you enjoyed.